Perfect. Thank you so very much, Dr. Ruchi. I'd like to thank everyone for being here today. I know that some of the colleagues actually are here in person in CG98. I would like to thank them also for being here. I hope you all have had a great summer. And for the fellowship candidates, thank you for being with us. I hope you have had a great day so far. And this would be our first renal grant round of the year. Let me just start sharing my slides with you, and then I hope you are seeing what we are supposed to see. Do you have the right
Yes.
screen? Perfect. Okay. So today I'm going to talk about cardiorenal medicine, which has been my topic of interest for a long time. And I try to provide a reappraisal of what I know and what has changed. These are my disclosures. None of them is directly related to the topic of my talk today. So today, I'm going to start with an example of a paradigm shift in medicine, show you how that applies to cardiorenal medicine, and hopefully provide you with some updates in the field of cardiorenal medicine that may change your view of this concept. And at the end, I'm going to use these elements to come up with a proposal on how cardiorenal syndrome can be defined in 2024, in my opinion. So how long does it take to see a paradigm shift in medicine? While complete paradigm shifts are fairly rare, I have to say that changes do happen. I think most of you agree with me. There is no good number, but we are typically talking about decades when we talk about paradigm shifts. And I want to put in a spotlight hepatorenal syndrome, which in my view is a hepatic form of cardiorenal syndrome. So some of you might remember that I had a renal grand rounds a couple years ago, where I mentioned that the current view of hepatorenal syndrome, which is summarized here, has been changed in some ways because now we know that there is also an entity that we call cirrhotic cardiomyopathy. And there are some pathways through which the liver that is diseased will affect the heart, whether we see it clinically or it is subclinical. Then I was telling you that it's a little bit hard for me to think that we have a diseased heart and there are some elements of cardiorenal syndrome, key elements of cardiorenal syndrome that are involved, yet there is no relationship between the heart and the kidney here. Then I suggested that we do have cardiorenal syndrome here. So these three elements are here. I thought we can call it hepatocardiorenal syndrome, right? So if this idea were true, some of the things that we typically do should change. Okay, one of them is, for example, that any patient that comes and you think this patient has hepatorenal syndrome should have cardiac evaluation. One of them is this. Another one that is probably more important is the diagnostic approach actually to hepatorenal syndrome, if you think about it. Well, this paper is New England Journal of Medicine, February of last year. Dr. Mitra Nadim from USC wrote this review article on what we call these days hepatorenal syndrome AKI, or in the past we called it HRS type 1. To make this a little bit easier to read, let's clean it up. So she's looking at different times and different definitions of hepatorenal syndrome here. Okay, starting from 2007. Actually, the first one I have seen is 2005, but probably she didn't have enough space to put all of them here, and goes all the way to 2019. Something that draws your attention is that when you go into the details of the definition, each of them is referring you to the previous one. Go look at the 2007. Go look at it, goes backwards. So from 2019 is telling you go to the origin. When you look at the origin, let me make it bigger. It is what you are all know. You want to make a diagnosis of hepatorenal syndrome, you should stop the diuretic, and you should give at least 2 days of albumin to all these patients for volume expansion. And if you do not believe this, look at the 2019 paper. It's here. This is Dr. Angeli or Angeli. I don't know what is the right pronunciation. This is the diagnostic criteria they put. They say the same thing. You want to make a diagnosis, give these patients 2 days of albumin. This is in 2019. You remember that in 2021, confirmed trial came out. And if you remember, actually confirmed trial was the basis on which actually terlipressin was approved by FDA for use in the US, while it was used for 2 decades in Europe, okay? Something that caught our attention when the positive response, the results of confirmed trial came out, was that, hey, it seems that there is some respiratory failure with terlipressin group. Be careful. There is a whole host of explanations why this happened. You can talk, if you want to go through the literature, you will see a lot of things. The dose of albumin was twice the dose that was used in previous trials. Terlipressin has an impact on lung vasculature. The impact of terlipressin on afterload. There are lots of different explanations for that, but albumin has been, I would say, matter of some concern for some groups to say that, hey, is it a good thing to use albumin for everyone? How many other diseases and syndromes do you have that you first treat the patient to make the diagnosis? Think about it. For these patients, you tell them, give them 2 days of albumin, then I will tell you if the patient needed it or not, right? If you think about it. So there has been a lot of, anybody who has been in clinical practice has been thinking about it probably, or at least many people have done. End of last year, there was a consensus guidelines coming out, big one, 19 countries, 33 experts about albumin in cirrhosis. And they asked Dr. Kuratalo and me to write something about it, an editorial commentary. Over there, we also wrote that we think that there might be some detrimental effect of use of albumin for everyone, especially after confirmed trial. I'm not claiming that we said this, everybody realized it. As I say, most people were thinking about it. Most people that I had been talking about in the field of volume overload, heart failure, and so on. So, believe it or not, July of this year, last month, ATKI, which is a big group of experts, along with the ICA, which is the International Club of Ascites. This is the main group that started the definition of hepatorenal syndrome. They got together and came with this idea that, hey, we think that we should not give albumin to everyone for 2 days just because we want to make the diagnosis. So it says that we think the patients who are euvolemic or have evidence of intravascular fluid overload, it might not be appropriate and might end up giving them congestion. 2024 July. So if you think about it, it took us 2 decades just to start changing the recommendations. I don't know how long more we are going to need for this to be expanded and used widespread. But for me, starting today, if I see a patient and I suspect hepatorenal syndrome, I wouldn't necessarily give the patient albumin just to make the diagnosis. This was the first part of my talk. Let's go to the next part, which now we are going towards cardiorenal syndrome. Cardiorenal syndrome, since around early 2000s, I would say, there has been a lot of discussions about the interactions between the heart and the kidney. Paper after paper came out. Anemia was one of the things that were at the beginning thought that it is a key element. Then we thought that it is important, but it doesn't have a key role. And there were papers after papers that came about cardiorenal syndrome until 2008, where Professor Ronco, along with a few others, they decided they are going to formalize the definition and they are going to provide some categories. This is what they decided this would be a good definition for cardiorenal syndrome. Disorder of the heart and the kidney, whereby acute or chronic dysfunction of one organ may induce acute or chronic dysfunction of the other. As you notice, there are two elements in it. One is that it is chronology based. It is acute or chronic. You need to make a distinction between the two. And second is that it has some directionality to it. Is it going from the heart to the kidney, or is coming from the kidney to the heart? Then what I think was appealing to most people in medical community and just make this a major change in terms of cardiorenal syndrome definition compared to all other definitions was that they were able to come with some categories. You all remember type 1, type 2, type, and you go. I'm not going to talk about these types actually today because you will see why I am not such a big believer in this actually. And so if you want to see how it impacted the cardiorenal community, there is a paper that just came in June of this year, looked at the cardiorenal syndrome literature with consistent. It's a bibliometric study. It just tells you that up until 2007, 2008, we are here, and then look at the growth. It is the last 20 years of literature. They actually looked at which groups are working. These are different groups in different parts of the world that are working. And the bigger the circle, the most is the impact. And you see CardioRenal being at the center of the literature in this zone. So it started then, but obviously it doesn't end then. After everything, we start using some concept, a new syndrome, then we start always to improve it once we are using in the clinical practice. So each group came up with ideas to improve it in their own way. One of the ways that you would think that this is a good way to just improve it is by expanding it beyond a pure clinical entity. Let's add some other dimensions to it. What do you mean? I mean that here, this is our suggestion. We said, let's call it cardionephrology. And we add a futuristic educational approach. Let's add education. Let's start a fellowship on this. A fellowship that is called cardionephrology. The two elements are together and we teach people. And actually the next year, it was in 2018, we suggested that. 2019, we went to Rome, cardionephrology. It was actually the meeting's name. And we went and presented this to the community. So what was it included in it? Inpatient, outpatient, all we went through the different, basically this is the curriculum that we were suggesting for such a fellowship. There were other groups that came up with other names and a little bit different from this. Our own Dr. Hatamiza came up with nephrocardiology and added research also that we need to do research in it as well. There is a Spanish group that came with a different name that has been published on it. They are different from each other, but the general concept is that going beyond a pure clinical entity, adding some other dimensions to it. That was one of the efforts. Another effort to expand this concept was, why just the heart and the kidney? They do share more than the blood. We need to think about other stuff. Okay, what was their I would say, argument to need more than the heart and the kidney? In 2011, this is the European work group of cardiovascular work group of the European Renal Association, similar to our kidney committee of the AHA, for example. They say for a new syndrome, you need to have a number of characteristics that this syndrome that Professor Ranko has suggested does not necessarily qualify for it. One of them is that definition is not that clear and the staging and all those are very arbitrary. And this is my suggestion, my actually example. They didn't say it, but in my mind also, it has a little bit of I would say there are holes in this. For example, you see a patient has benign prostatic hyperplasia, has AKI, obstructive AKI, gets hyperkalemia, and so he gets arrhythmia. By definition, this patient will have cardiorenal syndrome type 3. It is good, yeah, it is good, but it is unusual obstructive AKI. Why do you call it a different name and think that you have come up with something new? So it is a little bit, I would say, there are some inconsistencies, at least we can say. The second is that the elements of a syndrome typically should be synergistic rather than just additive to each other. And the cardiac disease and the heart failure do not seem to have a synergistic impact. They have an additive impact. There is a paper, I didn't put it, I first put it, but in the interest of time, I took it out. Dr. Halimi has written 500,000 papers in France, gone through one by one. They looked at it and they didn't see a synergistic effect between the CKD and heart failure. And then the uniqueness of treatment decisions. When you just label somebody SIADH, this is the syndrome where AVP is high inappropriately. All of a sudden, you have some treatment options that is different from previously when you didn't have this diagnosis. Then you need to use Vaptans. Then you need to be on, I would say, free water restriction. But before that, you didn't have that. So for this syndrome, it didn't seem that there is a lot of uniqueness of treatment decisions. So as such, they came up with the idea and they said that we think CardioRenal syndrome is a good educational concept, but with limited practical utility as a diagnostic or management tool. So they criticized it, but they didn't offer something instead until last year. Last year in CJSN, we have a paper that came out, from CardioRenal syndrome to chronic cardiovascular and kidney disorder. They call it a conceptual transition. And this is mostly a European group. So what do they suggest? They suggest we will have cardiorenal component of this disorder and kidney component. And I don't go through the details of it, but basically it tells you, you have some chronic aspect in the kidney, you have some chronic aspect in the heart, then you have this disorder. And some of them, I have a little bit of difficulty thinking that this is a progress. It's just something new, not much different from previous concepts. For example, if you think about a patient who has atrial fibrillation and happens to have some, I don't know, is slightly overweight, so has some albuminuria of 50 milligrams per gram of creatinine, atrial fibrillation, albuminuria, you have CCKD. So what? No, we treat you the same. You have a new name for it. So I don't want to criticize. They are not here to defend themselves. Actually, I have asked them, they are going to write a paper in cardiorenal medicine to expand on this. But the point is that I do not see it very different from what we already had. And there is another problem with the chronic parts of this syndrome. And I want to mention this here, is that the animal models are not really that great. Look at the left side of this graph. These are rats. Unilateral nephrectomy, MI or control. This is their proteinuria, not much different. Okay. As soon as they have unilateral nephrectomy and MI, look at the proteinuria. Wow, this is something. They have chronic cardiorenal syndrome, apparently, right? And to make it even more robust, look, if you have mild MI versus moderate MI, your proteinuria is different, supporting the idea that the synergistic effect of these is real, right? So that's what they wrote. They said MI enhances progressive renal damage in an experimental model of cardiorenal interaction. I completely agree with them. It was in 2004. 4 years later, same group published another paper, similar paper. This time, they looked at the sham, MI, 5-6 nephrectomy, and MI. This time, it didn't pan out. The proteinuria was not that much different. And when they looked at the histology was actually completely the same, similar. So they said the exact opposite of what they had said 4 years ago. Hey, it doesn't seem that MI is that beautiful, that worked. It's good for them. They took two papers out of this. But for us, we are back to square zero, right? So the animal models of chronic cardiorenal interactions, at least to this state, are not that robust. We should keep that. in mind. So when you go after this, there is another group that came out just end of last year, November of last year, and this is a major group. This is AHA. This is the Presidential Advisory Group. They said, hey, we are going to change the whole landscape. Let's talk about cardiovascular kidney metabolic syndrome. Let's shy away from cardiorenal syndrome. So what's the definition? Interactions between the metabolic risk factors, two of them, obesity, diabetes, and the usual CKD and cardiovascular system, and then they say which cardiovascular systems. Basically, if you look at it, the CKM syndrome has obesity, CKD, CVD, and diabetes. To make it even more interesting, categorize it and make it more colorful for us, they came up in circulation, 5 stages of CKMS, stage 0, no risk factors, all the way to clinical. And I don't go through the details of it. Well, is it reminiscent of something to you? To me, it is the same as metabolic syndrome that we had in the past. We have talked about it. Why not? If you want to add something to it, add fatty liver to it. Why not? All of them are endothelial dysfunction, right? You want to show that. So not only that, they went another step. They said, based on this model, we are going to provide you with prevent equations. What are these? These are primary prevention models, 6.6 million individuals. So it's a robust model. We have to admit the equation, the formula. It is race-free, which is the new tendency in medicine, thankfully. And then they looked at the predictors, and they said you can add something else to make it even more holistic. This is their online calculator. You can Google it, and you will see it. Prevent, online calculator. So you have a number of elements that you put in. eGFR is an integral part of it, but also you want to make it more robust. You can add albuminuria to it, hemoglobin A1C, and also the markers of social deprivation to get a better idea of where you are. And then they came up with some beautiful, beautiful diagrams. Women versus men, all cardiovascular disease, 10-year risk factor. Then the colors are here. The more risk factors you have, the more you are at risk. Then they said, as opposed to previous models, we can also tell you about heart failure, which is different. In the past, it was all atherosclerotic cardiovascular disease. They have 10 years also, 30 years as well, but I didn't include it here. In that paper, if you are interested, you go there, you will see all of them. They are good. They look good. How helpful they are, I'm not sure. You know, when you look at this calculator, you have 12 minutes to see your patient in the clinic, and you have this calculator to, I'm not sure how much we are going to use it as clinicians. So if I want, this is my comments on these initiatives. I think these initiatives are really good about the comorbidities and chronic conditions, but I think in clinical practice, they have very limited applicability. And I write here, this is reminiscent of metabolic syndrome to me. How many papers have you seen coming about metabolic syndrome? The name has changed, obviously. They don't call it, but the concept is the same. CardioNephrology, or the names associated similar to it, they are good. They are more of a conceptual framework. They are not a real practical entity. And I think they are too broad. Honestly, when I was putting all these curriculum together, I'm not sure how practical they are. So we are going back to square zero. We have our own cardiorenal syndrome, in my opinion, and we need to do something about it. We need to update it. The question is, how? This would be the third part of my talk. I give you the new developments in this field. We have the definition, and with these developments, we try to change these definition to come up with something new. That would be the next few minutes that I'm going to talk about this. Number one is, I know it is very sexy to say, let's be comprehensive, it is a trap. Don't do it. As much as you want to be comprehensive, you lose precision. You cannot focus then if you are just going at the big picture. So if you look at the 5 elements of cardiorenal syndrome that were offered, I would just remove the chronic parts and the type 5 that is actually secondary. I just stick with the first one. I do not have it. If I don't have other types, I don't have to call it type 1. I call it cardiorenal syndrome. This is the starting point. Acute heart failure followed or associated with acute kidney injury. Simple man, simple concept. The next thing that many of you have heard from me, if you have been in this division, but for some, especially the fellowship applicants, it might be new, is that is really the AKI in acute heart failure a real AKI? Is it real? So if you go back to the definitions, you go back to 20 years ago, 2003, Dr. Smith and, sorry, somebody said something? Okay, perfect. So Dr. Smith and his colleagues decided to look at the worsening renal function, the impact on mortality. They found out that if it goes above 0.3 milligrams per deciliter of change in creatinine, if my creatinine goes up by 0.3, or if my estimated GFR goes down by more than 25%, 25%, then my hazard ratio goes above 1. It becomes meaningful. They suggested we take these two as definitions of what they called worsening renal function, WRF, in acute heart failure. Several studies later, 2012, for example, Marco-Metra, they came up with another idea. They say, hey, worsening renal function should only interpreted in the context of congestion. If I have worsening renal function and I am congested, my survival is bad. But if I am decongested, I don't have congestion, despite having worsening renal function, it doesn't seem that my survival is affected. Basically, it implies that the driver of the outcome in acute heart failure is not the renal function, it's the fluid overload. As much as we nephrologists might be hurt by, our feelings may be hurt by this. And several studies have shown this, even they put the title of their study. Is worsening renal function a bad sign in acute heart failure? Several studies later, and this time I want to use a nephrology study in this group is our nephrologists. They showed the same thing. They looked at the GFR. It shows you that the acute decline in eGFR is associated with higher risk of death. At the same time, it also shows that if you have evidence of decongestion, as shown by lowering BNP or increasing hematocrit, then you will have better outcomes. Your risk of death comes down. So decline in GFR increases or is associated with increase. Decreased congestion is associated with better outcomes. These are in isolation, separate from each other. What if we took them together and look at it? It is very meaningful. It's the same concept. Your GFR is bad if you are congested. If your BNP comes down, meaning that your congestion comes down, the importance of GFR is lost. Your kidney is not as important as you thought. The same concept is hematocrit. My hematocrit goes up, I am decongested, then the importance of GFR is lost, okay? So why do you think we should call the AKI or worsening renal function? Per me, I call it rise in serum creatinine. Basically, they have come up with all kinds of names for it. WRF, benign AKI, AKI, pseudo WRF. I think rise in serum creatinine is only descriptive, does not convey any form of prognostic or mechanistic implication. If you don't know how it's impacting your survival, why do you call it AKI? Okay, that is my suggestion. It might or might not be accepted by you. With CardioRenal, we wrote actually, when we were writing, I think, an editorial on a paper, we mentioned it for the whole thing that from now on, we're going to use RSC and heart failure. So let's change our cardiorenal syndrome definition a little bit now that we know about worsening renal function and call it rise in serum creatinine in the absence of expected decongestion. This is based on what I just told you. This is the first step. What about urine? Should we look at it or just we have enough? Serum creatinine does the job. There is evidence that we need to look at the urine as well. Why? Here is a beautiful study. It looked at patients with acute heart failure who were on 2 grams per day of sodium diet and looked at how they did over time. If during the admission they had a positive sodium balance, they had a worse survival compared to those who had negative sodium balance. It is important to know, but I don't think it is surprising to anyone listening to me today. What may be surprising, however, is this side of it. They tell you if you have positive sodium balance, even if you have lost fluid, you are in a bad shape. Basically, they're telling you, look at sodium, look at urine sodium to say what treatment is efficacious. Don't look at the weight and say, great. This is basically what it is telling us. Whoever has dealt with patients with acute heart failure knows it very well. You start giving them some diuretic the first day, perfect urine output. Next day comes down, next day is the same. The first day, great response, then the response is kind of blunted. Urine output, days. When they adjust it for the milligram of the diuretic, it actually loses its importance. It seems that we might be doing something wrong with the dose. If you adjust it for the dose of my diuretic, I have had the same amount of sodium. Is it true? Let's take a look at the 24-hour urine excretion. First day, super high. Second day and third day is coming down, okay? Let's adjust it for the diuretic, still the same. What does it tell you? You start a patient on a dose of diuretic. First day, they have a great response in terms of natriuresis. You are not changing the dose of diuretic, yet the urine sodium comes down on its own, probably because of the internal mechanisms that we have, the defense mechanisms that we have. So the response to diuretics comes down over time. This is what you and I, we need to remember in terms of sodium excretion in the urine. That's why the recent idea is that conventionally we go with fluid-based. When a patient comes with acute heart failure, we look at their urine output, weight, intake output, and decide how to use diuretics. This is conventional, this is fluid-based. We should shy away from this and go to the right side. The contemporary, what is suggested, this is European Heart Journal, these are the guidelines. Say that, hey, let's first do it early. Within a few hours, check it, and then check urine sodium and decide what the dose of diuretic should be. Forget about the weight, forget about the balance, go with urine sodium. I don't say that forget about it, maybe I should have said that. Think about urine sodium more seriously, okay? This is the bottom line. So last year, I wrote, these are the studies that are just in the pipeline. We are going to see what they are going to do with natriuresis-guided therapies in heart failure. And it was just 2023, not knowing that by now, 2 of them are already out. One of them is PUSH acute heart failure trial. It showed us that if we look at the urine sodium and adjust the dose of diuretic based on our urine sodium, we'll have a much better natriuresis, much better, I correct myself, better. It is 20% increase. And actually, I just wrote it recently for somebody. This is the job of it. You're looking at the urine sodium, you're adjusting the dose of diuretic based on that. This is expected. You should be getting more urine sodium in that. So it is not, we can at least say it is feasible, but it is not unexpected or surprising. The same is enact heart failure. This one showed 60% increase if you use by protocol versus the conventional therapy. If you look at the urine sodium and you adjust the dose of your diuretic based on your urine sodium, and you ask yourself when, how. If this is your question, the next slide is answering your question. This is the algorithm for acute heart failure therapy, European Society of Cardiology, early urinary sodium guided. I don't go through the details. I just remind you that there are some points. One of them is 2 hours. One of them is several hours later. You look at the urine sodium and you decide if you need to change. And what is that number that you want to remember for the fellows? 50 millimole per liter. So you check the urine sodium. If it is less than 50 millimole per liter, you are not in a good shape. You need a change of a strategy if you can. Well, one thing that is interesting from all these algorithms, you know what happened? The side benefit of this, now we have a definition for diuretic resistance. Anytime you have a urine sodium of less than 50, despite optimal or appropriate diuretic therapy, you can consider this diuretic resistance. Up until now, we didn't have it. So this might be something that you need to consider if somebody asks you about the definition of God. I want to give a shout out to Dr. Belal. I don't know if he's on the call or not. Right after his fellowship, he wrote a paper on this, urine sodium and acute heart failure, time for reappraisal. If you want to know more about urine sodium, the impact on clinical outcomes and all those, he has gathered quite a few studies in that paper. So if we want, based on this, change our definition, we will call it now this way. A syndrome where the same thing, rising serum creatinine or diuretic resistance. Now you don't have to linger in, you have a name, you have a number that you can use. Okay. Next step is, how should I feel when I see improvement? Amir, don't be that negative. You're all talking about worsening renal function, rising serum creatinine. Give us something hopeful. Give us something good. Sure enough, I will give you improvement in renal function. Do you want to be happy about it? Let's take a look at it. This is a study of almost 900 patients. Nearly 1/3 of them showed improvement in renal function when they were in the hospital. So the patient comes with acute heart failure. We start them on diuretic therapy. We look at their serum creatinine, and serum creatinine gets better. What is the definition? The definition is increase in GFR by more than 20% or so. That would be improvement. So what would be the mechanism? One mechanism would be that because we are increasing the we are decreasing the intra-abdominal pressure by resolution of congestion. We are decongesting the patient, intra-abdominal pressure is going down, kidney is breathing. This is I wish they had done a better job, sorry, for this diagram. This is the reduction in intra-abdominal pressure. Don't be fooled. So as we go up, our intra-abdominal pressure is going down. As you see, as intra-abdominal pressure goes down, our GFR goes up. Okay. And we know that the net filtration pressure goes down when we have right-sided pressures, all the changes in the intrarenal hemodynamics. Okay. Another hypothesis would be that maybe I look at improvement in renal function. This is the serum creatinine. The patient has come to the hospital here on admission, and I see improvement in renal function until discharge. Here, for example, the GFR started at 52 and ended up at 64. Maybe I have had a pre-admission worse renal function that I missed, meaning that if I had gone back and looked at before the admission, the patient had increasing creatinine, but I didn't see it because he was admitted here. I saw this part of it. So in this actually study, they saw that the pre-admission GFR was pretty much the same as when they were discharged. They had just seen on admission, the GFR had been lower. So what do you think the impact would be on the outcome? It is improvement in renal function, right? Here is what happens. Improvement in renal function associated with worse survival. Here is the good news you were giving us. Stable renal function, better survival compared to improvement in renal function. This is something that kind of blows your mind, and you want to make sure you are dealing with the real deal. It's not some statistical thing. Let's talk about persistent versus transient improvement in renal function. Some patients come, their kidney function gets better, but gets again worse before they get discharged. Some patients, the kidney function gets better, stays good until they get discharged. Persistent versus transient. So these are some patients. This would be what they do. Basically, they have improvement in GFR that stays until the discharge. Persistent improvement in renal function. As opposed to another group, they have improvement in renal function, but what happens is that by the end of the time, when they are ready to be discharged, the kidney function is back to what it was. Transient versus persistent. What about this and the outcome? So this is the 900 patients. 13% had transient and 18% had improvement, persistent. Okay. What's the impact on the outcome? Sure enough, the same concept is here. Persistent improvement in renal function is associated with worse survival compared to those without improvement or with transient. More than anything else, it tells me that probably what we saw was real. But you know, these papers are from 15 years ago. Now we have neprilysin inhibitors. We have SGLT2. Has it changed? Do you have anything new to offer me, Amir? I do. This paper is from last year. Looked at the same concept. Stable renal function, worsening renal function, improvement in renal function. And this is the association with survival. What does it tell you? If you see a patient's serum creatinine is coming down, don't open champagne. It probably is not a good sign. And if you want to lump this up, stable versus dynamic. Dynamic is whether getting worse or getting better. Stable does not change much the serum creatinine. Basically, it's just like the blood pressure. Those of you who deal with a lot of blood pressure patients, you will see that. If you see a lot of variation in blood pressure over time, it is associated with worse outcomes. Same is renal function in patients with heart failure. And if you think that it was the same 15 years ago, they had shown the same thing. Stable renal function is associated with better outcomes compared with dynamic, whether getting better or worse. So let's change our definition still a little bit more. We call it now dynamic serum creatinine or diuretic resistance. You see that with new data, I am trying to update my definition. Good news for you, that's the last part. Can cystatin C or biomarkers help? That's the new hype, right? All of us love cystatin C, just check it, nephrology. Let me tell you the answer first up front, then I will give you the data. The answer is no. At this point, in 2024, they cannot help. The hope is that in the future, when we know more about them, they will be helpful. Cystatin C, creatinine, these are the biomarkers of renal tubular injury, NGAL, NAG, CHEM1. The creatinine goes up, the biomarkers remain stable. And I said even something more. As high as 0.2 to 1.3, the creatinine is moving, meaning that the creatinine of the guy was 1.5 when he came to the hospital. Now it is 2.8, yet the NGAL is the same. This is even with larger changes. And if another study lumped them up, no worsening renal function, no rise in serum creatinine versus rise in serum creatinine. The biomarkers remain pretty much the same. What about the combined? Maybe sometimes we combine biomarkers, they give us better efficacy. We have done this. No change. No correlation between the markers and the changes in serum creatinine when you are ADHF. Actually, when you look at it, they cannot have any impact on they cannot show you what the survival is just by looking at the biomarkers. Whether they show improvement, stable, or worsening, the outcomes are the same. So again, maybe in the future they can be helpful. At this point, biomarkers of renal tubular injury might not be helpful. There are several actually meta-analysis that came out that are saying differently, but when you look at them, the weight of some of the studies is so big in those that it is really not very meaningful. If you want to just challenge yourself, this would be the slide to do it with. This slide is telling me that if you have stable renal function, meaning creatinine has not moved much, and you have stable biomarkers, it is associated with the best outcomes in terms of survival. You know what is the worst? The worst is that when you see improvement in renal function and the biomarkers are also coming down, the exact opposite of what somebody may have thought, and the others will be in between. These are associations, keep that in mind. These are all post-hoc analysis, and this is a usual trial. Oh, this is Amir post-hoc analysis. That's great. Give me something that is against it without post-hoc analysis. There is none. What about the cystatin C? Same pattern. If my cystatin C goes up, the injury biomarkers go up, associated with better outcomes compared to the opposite. So again, to this date, cystatin C and biomarkers, we have a lot of hope for them for good reasons, but we need probably some time. So you know what, Amir? You gave us up and down, up and down, up and down. Tell us what you think. Based on all the studies that you gave us, what is your definition of CRS? This is my suggestion. So we started in 2008 with CardioRenal, who told us that type 1, type 2, type 1 thing, AHF, acute heart failure plus worsening renal function would define cardiorenal syndrome. Several years later, several studies later, we came up with the idea that let's acute versus chronic make them, and then we came up with rising serum creatinine. You remember, we didn't want to imply any form of prognosis with it, and then lingering congestion was a major issue. You saw Mark Umetra's paper, Wendy McCullough's paper, and several other papers in between that have said the same thing. That was in 2020. And then now we have come with the idea that it seems that it doesn't only rise, probably even decrease in serum creatinine might be associated with worse outcomes. Basically, it defines, it just identifies a sicker group of patients. It's not causality necessarily. It just tells us that this group of patients are sicker if their creatinine changes too much. So at this point, this would be my suggestion to call cardiorenal syndrome acute heart failure plus either dynamic serum creatinine or diuretic resistance as we went through. I put here biomarkers and cystatin C because I really think that they may have a role in the future, even though at this point. And I have been around enough that to know that this is not the end of it. I know that after me or I myself will come up with newer data, newer definitions, and newer things to discuss. Let me finish by the take-home message that I had for you. Number one is that paradigm shifts in medicine do happen. They are slow. Hepatocardiorenal syndrome may be an example. I'm not pushing hepatocardio. You can call it hepatorenal syndrome. There is a component of cardiorenal syndrome to it. And you know that the new thing is that we need to change the way even we define it, regardless of the treatment. When I was doing that renal grand rounds, I showed you that there is a study that tells you you have hepatorenal syndrome. Not only you do not stop diuretics as was suggested, you increase diuretics to get rid of hepatorenal syndrome. So let's see what happens afterwards. I also think that the attempts at more precisely delineate the cardiorenal interactions to be tend to be more comprehensive. I would say more comprehensive and less helpful, probably. CCKD and CKMS that I talked with you about would be two good examples of those, in my opinion. Also, I think that the newer developments that we have had in the field of cardiorenal syndrome, I think they mandate revising the original definition. You might not agree with the way I revised it, but I think hopefully you would agree that it needs to be revised in some way. And with this, I would like to thank you for your attention. I'll be happy to take questions. I think we have, yes, we have 7 minutes to go.